If you take a statin, give me 60 seconds. Your body may be whispering signals most people miss. Quick and safe at-home check. Has it become harder to sit and stand or climb stairs because of new weakness in your thighs or shoulders? Is your urine the color of tea or cola, along with widespread muscle aches, even when you stay hydrated? Have your eyes or skin turned yellow with intense itching or very pale stools? If any answer is yes, don't panic. Be prudent and talk to your doctor. Stay with me. Next, I'll show you the 6 signals doctors don't ignore and the number almost no one explains, the one that changes everything. Deciding about statins should consider your baseline risk, not an average. Would you rather decide with absolute numbers or by guessing? In plain English, NNT, number needed to treat, equals how many people like you need to take it for a few years for one to avoid a heart attack or stroke. NNH, number needed to harm, equals how many take it until one has an important side effect. The higher the baseline risk, the greater the absolute benefit. Smaller NNT. Quick win? Typical absolute reductions, all-cause death, 0.35%. Stroke, 0.39%. Heart attack, 0.85%. At your last visit, did anyone show you these numbers? Do you know your 10-year risk? Let's decode it together. Warning signal number 1, serious muscle injury, medically termed rhabdomyolysis. This condition is rare but represents a medical emergency requiring immediate attention. Here's what to watch for. New weakness in your proximal muscles, that's your thighs, hips, shoulders, and upper arms. You'll experience widespread muscle pain and soreness throughout your body, similar to severe flu-like aches, but more intense. The hallmark sign is dark cola-colored urine that appears brown, tea-colored, or reddish-brown. This occurs because damaged muscle proteins called myoglobin are being filtered through your kidneys. Fever, nausea, and general malaise frequently accompany these symptoms. Why this matters critically? When muscle tissue breaks down rapidly, it releases toxic proteins and electrolytes into your bloodstream. These substances can overwhelm and severely damage your kidneys, potentially leading to kidney failure. Certain medication combinations, particularly statins with other drugs, dramatically increase your risk. Your immediate action plan. If you develop these red flag symptoms, contact your doctor or emergency services immediately. Don't wait. Your physician will likely order a CK blood test, that's creatine kinase, which measures the level of muscle breakdown enzymes. Based on results, they may immediately adjust medication doses or completely discontinue certain drugs to prevent further muscle damage and protect your kidney function. Warning signal number 2, immune-mediated necrotizing myopathy, specifically anti-HMG-CR myopathy. Research shows this occurs in only 2 to 3 of every 100,000 patients taking statins, but represents a medical emergency. Here's what distinguishes this condition: progressive weakness in your proximal muscles that gets worse over time. Your CK levels will be dramatically elevated, often 10 to 50 times normal. The critical difference is persistence. This weakness does not resolve upon statin cessation, unlike typical muscle toxicity. Why this is uniquely dangerous? Statins increase HMG-CR expression, leading to immune system activation against your own muscle tissue. Studies from Johns Hopkins show 85% of patients over 60 reach normal strength within 4 years, while only 45% under age 50 recover fully, emphasizing early intervention importance. Treatment success rates? Research shows 25% achieve remission without steroids, while 90% respond to triple therapy with steroids, IVIG, and immunosuppressants. Glucocorticoids, azathioprine, and methotrexate are generally effective treatments. Critical questions for your healthcare team are: did weakness continue despite supervised medication cessation? And have you tested for anti-HMG-CR antibodies? Recent studies confirm antibody levels correlate with CK levels and muscle strength. Early recognition and prompt immunotherapy prevent permanent disability.
Warning signal number 3, New onset diabetes or elevated blood sugar levels after starting or increasing statin medications, particularly high-intensity statins. Here's what to monitor. Rising fasting glucose levels or hemoglobin A1C after beginning statin therapy or dose increases. Research shows high-intensity statins carry 36% increased diabetes risk, compared to 10% with moderate-intensity statins. The majority of new diabetes cases occur in people already close to the diagnostic threshold, meaning those with prediabetes are most vulnerable. Understanding the actual risk. Studies indicate 99 people need treatment for 5 years to cause 1 case of diabetes. That's approximately 1% absolute risk. Large-scale analysis of 91,140 participants showed 9% increased relative risk for incident diabetes, but this translates to small absolute numbers. Critical risk-benefit perspective. For every 54 new diabetes cases, statins prevent 134 cardiovascular events or deaths in high-risk patients. Meta-analyses demonstrate 9% reduction in all-cause mortality and 13% reduction in vascular deaths with statin therapy. Your monitoring plan. Regular A1C and fasting glucose checks, especially if you have diabetes risk factors. Maintain healthy lifestyle habits, proper diet and exercise. Most importantly, never discontinue statins solely due to diabetes concerns without consulting your physician, as cardiovascular benefits typically outweigh diabetes risk for most patients requiring statin therapy. Warning signal number 4. Acute kidney injury signal with high-potency statins, particularly during the first months of treatment. Here's what to watch for. Decreased urine output, new leg swelling that doesn't resolve overnight, and persistent dark urine combined with muscle pain. Research from over 2 million patients shows high-potency statins carry 34% increased AKI risk within 2 years of initiation. High potency is defined as rosuvastatin 10 mg or higher, atorvastatin 20 mg or higher, or simvastatin 40 mg or higher daily. Understanding the observational evidence. Large multinational studies demonstrate this signal requires vigilance, not alarm. The mechanism appears independent of rhabdomyolysis, suggesting direct renal effects. However, data showing statins cause AKI without muscle breakdown remains limited and requires careful interpretation. Your home monitoring deliverable. Maintain a comprehensive 7-day hydration and urine color log. Record 3 times daily, morning, noon, and evening. Document fluid intake, urine color changes from pale yellow to amber or darker, and any accompanying symptoms like swelling or decreased frequency. This monitoring helps distinguish normal variation from concerning patterns that warrant medical evaluation. Early detection through systematic observation can prevent progression to serious kidney injury. Warning signal number 5. Clinically significant liver injury from statins. Very rare, but potentially serious. Here's what demands immediate attention. Jaundice, meaning yellow discoloration of your eyes or skin. Intense, persistent itching across your body. Very pale, clay-colored stools combined with dark amber or tea-colored urine. Right upper quadrant abdominal pain under your ribs. Understanding the research evidence. The Drug-Induced Liver Injury Network studied 22 statin cases among thousands enrolled. Overall hepatic injury risk is approximately 1%, similar to placebo rates. However, severe cases can present with jaundice and prolonged INR, with 1 recorded fatality. Patterns vary widely, with 18% developing persistent or chronic injury, particularly those with autoimmune features. Critical timing and demographics. Cholestatic liver injury occurs in roughly 1.47 per 300,000 patients. Most cases develop within weeks to months of starting therapy, with atorvastatin and simvastatin most frequently implicated. Your immediate action plan. If you develop these warning signs, contact your healthcare provider promptly for liver function tests, including ALT and AST levels. Your clinician will evaluate other potential causes and may temporarily hold your statin while investigating. Early recognition prevents progression to severe hepatotoxicity requiring liver transplantation. Warning signal number 6. Hemorrhagic stroke risk in specific contexts requiring careful consideration. Here's the evidence context. The landmark SPARKLE trial studied 4,731 patients with recent stroke or TIA treated with high-dose atorvastatin 80 mg daily. While atorvastatin reduced total strokes by 16%, it showed concerning specificity. Atorvastatin group experienced 218 ischemic strokes and 55 hemorrhagic strokes, compared to placebo's 274 ischemic strokes and 33 hemorrhagic strokes. This represents a 66% relative increased incidence of hemorrhagic stroke. Understanding the net clinical benefit. Despite increased hemorrhagic strokes, atorvastatin prevented 56 more ischemic strokes than it caused hemorrhagic strokes. The absolute 5-year reduction in major cardiovascular events was 3.5%, with number needed to treat of 45 patients over 5 years to prevent 1 stroke. Critical decision-making contexts. Patients with previous hemorrhagic stroke require individualized shared decision-making, especially when combined with anticoagulants. The American Heart Association guidelines place this decision in clinician hands, emphasizing comparison of individual hemorrhagic recurrence risk versus ischemic event risk. Your clinical approach. History of hemorrhagic stroke doesn't automatically contraindicate statins, but demands careful risk-benefit analysis considering bleeding risk factors, anticoagulation status, and overall cardiovascular risk profile.